Dear ESTS members and webinar attendees, my name is Lieven de Piepere, your moderator for today. First of all, I would like to thank many of you for filling out our questionnaire on the educational webinars. Results will be made available as soon as they have been processed. This webinar is the second one of the 4th season of the ESTS educational webinars. And the subject for today is non-intubated thoracic surgery. As shown by a new massive subscription today, this will be a great webinar again, led by 2 experts in the field. I'm very glad to introduce you to a team that I was fortunate to visit back in Rome some years ago. Professor Mario Dauri is Associate Professor Anesthesiology at the Tor Vergata University in Rome. And Professor Eugenio Pompeo is Full Professor Thoracic Surgery at the Tor Vergata University in Rome. Professor Pompeo has been a pioneer in different fields of thoracic surgery with publication on subxiphoid resections back in already 2007, for instance. But together with their Awake Thoracic Surgery Research Group, Professor Dauri and Professor Pompeo are pioneers in non-intubated thoracic surgery, being an example for many groups worldwide who started this type of surgery. Therefore, I'm sure this team is ideal to give you some insights in non-intubated thoracic surgery today. As usual, we will ask your interactivity, so be ready to answer some poll questions, and please ask as many questions as you want to the experts. We will first have two presentations from both experts, and afterwards we can have the discussion. Professor Pompeo will start with his lecture, so I give you the word.
Thank you, Lieven. Thank you, Lieven. Good evening to everybody. First of all, I would like to thank the Society for this kind invitation to talk about this topic, which we are involved in since quite many years. And I will share with you the presentation. So we will make an overview about the main indications and results of non-intubated thoracic surgery. We all know that the rationale that moved us to be interested in this kind of surgery was trying to avoid side effects of intubation, general anesthesia, and single-arm mechanical ventilation in order to maintain more physiological, muscular, neurologic, and cardiopulmonary status, to minimize the overall procedure-related trauma, and eventually to improve the outcomes. The story started with us with this small prospective study about feasibility and results of awake thoracoscopic resection of solitary pulmonary nodules, published in 2004. And actually, so far, there are quite many surgical procedures that have been performed, at least anecdotally, by non-intubated thoracic surgery. You can see that starting from simple procedures, such as surgical management of pleural effusion and emphysema, going ahead with surgical management of a primary spontaneous pneumothorax, lung biopsy for interstitial lung disease, mediastinal biopsy of undetermined mediastinal masses, and going ahead with thoracic sympathectomy, bolectomy, lung volume reduction surgery, wedge resection, and metastasectomy, thymectomy, and going ahead even with more advanced major surgery such as lobectomy and segmentectomy, and even sleeve lobectomy and tracheal resection. The question is, which of these surgical procedures not can be performed, but should be or can be of advantage to be performed with? A survey from the European Society of Thoracic Surgeons that we have published in 2015 and have shown that there were already some groups interested in this kind of approach, performing mainly pleural biopsy drainage and talcage for recurrent pleural effusion, pleural decortication for emphysema, and lung biopsy for interstitial lung disease. You can also see that already in 2015, there were several institutions and surgeons worldwide which were dedicating somewhat to this kind of approach. And also you can see that at least in a small randomized study about pleural effusion, for example, we have suggested, let's say, that this kind of approach under thoracic epidural anesthesia might be beneficial in reducing hospital stay and the amount of daily pleural fluid drained. Another optimal indication can be performing surgical biopsy of undetermined interstitial lung disease. We published the first series in 2013, and this is more recent retrospective multicenter study published in 2019 that have shown, that in 112 patients, feasibility, morbidity, and diagnostic yield were 95%, 7.1% for morbidity, and 96% respectively without mortality. So this, for example, is a practical indication which we could recommend, because, as you know, thoracoscopic lung biopsy of interstitial lung disease is a simple procedure which had quite a high morbidity when performed by standard thoracic surgery. This is another simple procedure which can be recommended because it is easily performed, is performed in patients with nearly normal respiratory function. So patients, young patients with spontaneous pneumothorax can be optimally treated by non-intubated thoracic surgery. And these are very recent results by a large multi-center randomized study from China, 10 centers. You can see that the results, was a non-inferiority trial demonstrating in two groups of 162 versus 163 patients that there were no differences in morbidity rate, in hospital stay, and so this study has demonstrated that non-intubated thoracic surgery for this indication is non-inferior, at least non-inferior to standard intubated thoracic surgery. Another very good indication for non-intubated thoracic surgery in our hands was lung volume reduction surgery. I can say that we published in the early 2000s about our original non-intubated, non-resectional lung volume reduction surgery method. We have progressively refined this method, and more recently we have analyzed the results of this quasi-lobar so-called minimalist lung volume reduction surgery. In this study, you can see that this is the technical details of the surgical procedure. We call it minimalist because everything is minimized to maximize the results. Uniportal approach, a non-intubated anesthesia by simple intercostal block, as you will see with Professor Dauri more in detail, a non-resectional method, and use of very small catheter, 15 French in size, to reduce the invasiveness of this procedure. If we look at the results, this study was comparing three methods, but just take a look about two of these, the quasi-lobar minimalist versus the non-awake resection, or the standard technique by intubated thoracic surgery. And you see that anesthesia time, operative time spent in the operating room, pain, operative morbidity, and hospital stay, as well as the overall cost, were all significantly reduced as compared with standard surgery. And this is a meaningful result. This is probably one of the most important slides I would like to show you, because it is one of the main reasons that moved us to prefer non-intubated anesthesia for several indications. You see here the results in oxygenation and PaCO2 in patients with impaired pulmonary function. And look at the most important behavior. 1 hour after lung volume reduction surgery, you see that patients undergoing lung volume reduction by intubated anesthesia have a fall in oxygenation as compared with preoperative value, whereas in the patients undergoing lung volume reduction by non-intubated anesthesia have oxygenation going back to preoperative values. And the same is happening for PaCO2. You see that under general anesthesia with intubation, PaCO2 start raising and continue raising a little bit 1 hour after surgery, whereas it coming back to baseline value in patients undergoing non-intubated anesthesia, whereas there is a rise in PaCO2 at end procedure. This is due to the pendular ventilation, the paradoxical ventilation that we have in patients with an open pneumothorax induced surgically. Another very good indication, this is another morbid procedure when performed in patients undergoing intubation and mechanical ventilation. You see patients with huge mediastinal masses. There is the risk after extubation of tracheal collapse, even after a single biopsy. By an awake or a minimalist non-intubated approach, you can easily take big bites for a safe diagnosis. Most of the times these masses are lymphomas, Hodgkin or non-Hodgkin lymphomas. And so through a simple intercostal block and a small incision as made for insertion of a chest tube, you can perform all the procedure quite safely. Another very good indication, even if it's not standardized, is the possibility to use a non-intubated anesthesia in patients with myasthenia gravis, either thymomatous or non-thymomatous. This, as we all know, is another delicate patient cohort because these patients can have problems, respiratory problems early in the postoperative period, going up to myasthenic crisis, which can oblige to admit them in ICU departments. By non-intubated anesthesia, this is avoided, so the postoperative recovery is almost immediate, and the respiratory function is saved in these patients. Another example of an urgent indication is this. This is an anecdotal case, but is a good clinical model. You see this patient with a chest trauma and bilateral hemothorax. He underwent thoracentesis. He already had a chest tube in the right chest, but you see here that he developed a clotted hemothorax, not drainable by the chest drain. He underwent an awake procedure with the treatment, the removal of the clotted hemothorax under awake anesthesia, and drainage of the left chest, and fully recovered early postoperatively. As far as lobectomies are regarded, we actually do not believe that lobectomy is a standardized indication and a really safe indication for non-intubated anesthesia. We do not perform it, whereas is it quite frequently performed in some Oriental countries like China, for example. You see that in this meta-analysis, these authors have found a greatly shorter hospital stay and chest tube duration, and as compared with patients operated on by HEVAS. But you see again that most of the studies were retrospective, and most of the authors are coming from China or Taiwan. This is another recent meta-analysis, which is based on 14 randomized controlled study. Once again, you see that the institutions are mainly two, or at least coming from Italy and from China, with some example from Korea, some series from Korea and Turkey as well. In this meta-analysis, the authors have found, I summarized the results showing that hospital stay was significantly better in the series, independent by the type of non-intubated anesthesia which was employed, and also that the morbidity rate, as you see in this forest plot below, was better in the series of non-intubated thoracic surgery.
Mm-hmm.
When looking to the potential advantages that we can have by this kind of approach and the level of scientific evidence that we can find in the literature, you see that an easier acceptance of surgery has almost no real scientific evidence, whereas reduced need of high dependency stay postoperatively, it has some significant results, at least a unicenter randomized studies or retrospective study with propensity score matching analysis, better perioperative respiratory function and oxygenation, reduce operative morbidity, shorter hospital stay. You see also that lower procedure-related costs, they start appearing also in multi-center randomized studies, and also interestingly, an attenuated stress hormone response and an attenuated immune response impairment, which can play a role even in a better survival in oncological surgery, which so far remain to be better elucidated, started in having some evidence in the literature. So what are in our hands the indications and contraindications with for non-intubated anesthesia, for non-intubated thoracic surgery? Our suggested indications are patients with significant risks for intubated general anesthesia. One example, lung volume reduction surgery is a perfect indication for this kind of approach, and simple and easy to perform procedures. So recurrent pleural effusion, primary spontaneous pneumothorax, mediastinal biopsies. More debated can be considered the indications for major procedures such as lobectomy, segmentectomy, thymectomy, and even more advanced indications such as tracheal surgery, which is actually performed safely in few institutions. Contraindications remain hemodynamic instability and morbid obesity, expected dense and extended pleural adhesions, which is an overall indication for minimally invasive approaches in general. Non-compliant patients and non-experienced surgical teams, of course, is a contraindication. Thoracic spinal deformity or coagulopathy only when thoracic epidural anesthesia is regarded, and central apnea syndrome for the risk of hypercapnia, because permissive hypercapnia is one of the potential adverse effects of non-intubated anesthesia, cranial hypertension with risk of seizures, and large and centrally located tumors, which is overall a contraindications for video-assisted thoracic surgery in our hands. So to conclude, our suggestions for future perspectives is to standardize indications for simple procedures, for example, management of pneumothorax pleural effusion, and promote fast-track programs, standardize indications in patients with impaired respiratory function, for example, lung volume reduction, embolectomy, lung biopsy for interstitial lung disease, very good indication. Define indication for lung cancer surgery, such as lobectomy, segmentectomy, and even metastasectomy in patients with and without comorbidity, and investigate results in combined minimally invasive strategies, including non-intubated anesthesia plus other approaches, such as robotic approaches, for example, the uniportal approach, and needlescopic approach. Finally, this also is an interesting topic to investigate comparatively the effects of non-intubated anesthesia on recurrence and survival in cancer surgery, which is a topic which is scarcely investigated so far. I thank you for your attention. Thank you very much.
Thank you very much, Professor Pompeo. I see that there are already some questions coming up, but I suggest to wait because some of these questions could maybe be answered by Professor Dauri in his presentation already. So we are switching to the presentation of Professor Dauri right now.
Yes, just a moment.
No problem. Take your time. So more on the anesthesiological aspects of the non-intubated.
Okay. Thank you very much. My name is Dauri. I am the anesthesiologist of the team of Professor Pompeo. And thank you very much for the invitation, discussing about a technique in which we are involved for many years, and a technique that seems to us from the beginning very stimulating because is very in direction of minimally invasive, not only surgery but anesthesia as well, and especially very important to follow the line of fast-track pathways in surgery. So I'm going to
we seem to have lost connection, so I'm very sorry for that. I think Professor Dauri pushed the wrong button. Yes, there he is. And the presentation is coming up. But the only problem is that we cannot hear Professor Dauri anymore. Mr. Dauri, we can see your presentation. That's perfect, but we're not able to hear nor see you anymore. I don't know what happened with your camera. Maybe you can push on the camera button again. Yep, thank you.
Okay, could you see my presentation?
Perfect, yes, we can hear and see you.
Okay,
just
I'm sorry for
perfect.
this.
No problem, no problem.
For this
We're
mistake.
listening.
Okay, okay. The question is NIVATS or IVATS, because our daily practice, like standard method, is to use double lumen tube, but we believe from the beginning of our experience that it could be not used, and because general anesthesia in thoracic surgery, especially in mini-invasive, have some well-known adverse effect. Airway trauma, ventilation-related lung injury. What Professor Pompeo was discussed some minutes ago is, for instance, the post-extubation crisis that is very well known by the anesthesiologists involved in thoracic anesthesia. One of the most important problems, but we monitor very well the level of our curarization, is the residual muscle relaxation of so-called PORC, postoperative nausea and vomiting. But one of the most interesting, particular event during lung ventilation is the increase of stress hormones and pro-inflammatory mediators related to mechanical ventilation. There is the problem of shunt
that could be minimized by the activity of the diaphragm of the dependent hemithorax. And during general anesthesia, there is the problem of inhibition of hypoxic pulmonary vasoconstriction. So, regarding to the inflammatory effect of one lung ventilation, we see this paper. This is 10 years ago, was published, in which we see the IL-6 and pro-inflammatory cytokines, very important rise in these 15 patients after the intubation and maintaining quite high at the end of the surgery. This is another paper published by our group in which we see IL-6 significantly rise in intubated patients. The conclusion is that VATS lung metastasectomy in non-intubated anesthesia had significantly less impact on both immunological and inflammatory response compared to the traditional procedures in general anesthesia intubated patients. This is another aspect about the surgical stress and the hormonal response that appear in very reduced, very different in NIVATS patient versus general anesthesia. So how can you do it? How can you reduce this problem? And answer is to use this kind of minimal invasive anesthetic approach using technique of neuraxial technique or peripheral or local anesthetic approach to manage this kind of patient without intubation, using spontaneous ventilation with patient awake, or otherwise use a peripheral approach with various kind of block associated to deep sedation and extraglottic disposable or not. This is the, for instance, what happens with non-intubated video-assisted thoracic surgery with high flow nasal oxygen, and you see that this is a Chinese paper that demonstrates the non-intubated VATS using TRIVE. This is acronym is transnasal humidified rapid insufflation ventilatory exchange with 20 to 30 liters per minute. The oxygenation is better, is significantly better than patient in intubated group, and CO2 is near normal, not so different respect the intubated group. The main peripheral technique that we use is neuraxial, with putting an epidural catheter at level 3 T5 T4, or paravertebral block, or erector spinal S block or intercostal block. In very recent, we start to try, we perform a small number of cases with a new technique that is very, very interesting, not just for the intraoperative use, but especially for postoperative analgesia with cryoanalgesia. This is a meta-analysis in adults, and this is very interesting because it's a no pharmacological approach and very long-lasting thoracic analgesia. This could be very interesting, especially in trauma or in very important surgery, but just not for NIVATs. These papers demonstrate that intercostal nerves are the best cryoablated just lateral to transverse process and before the collateral intercostal nerve branches. And in our patient, they are 4 at the moment. The analgesia is incredible, is impressive. All 4 patients have VAS 0 at the end of the operation until now. This is our the interest about this technique in the years is becoming more and more important in literature. We have a lot of jobs, a lot of papers published in the last year, but our interest is drawn by these 3 meta-analyses enrolling 70 studies and 7,100 patients. And the results of these 3 meta-analyses are very, very similar. In these studies, it's shown that we have a significant decrease in pain in NIVATS group versus EVATS. We have significant reduction in postoperative stays in the patient studies. As well, we have in studies significantly lower rate of complications, significant reduction in perioperative mortality, and a significant reduction in anesthetic time. This is very important because especially in hospital with high volumes, this problem is very relevant, not only for the patient well-being, but is a problem of economic and gestional aspect of our activity. So I can conclude that the studies support our initial hypothesis that non-intubated VATS is safe, effective, and feasible technique, and it can be a reliable alternative to general anesthesia in thoracic surgery. Thank you very much for your attention.
Thank you, Professor Dauri. Professor Pompeo as well, of course, for both presentations. We have still a lot of time for questions, and I see that a lot of questions already have been asked. My question to the presenters first, do you want to ask your questions to the audience first, or do we go through the questions from the audience?
We can go to the audience first, okay?
Okay, that's perfect. So let's start from the first question down in the questions bar. You can also follow them. This is a question: in the case of timomas, the probable myasthenic crisis theoretically is not triggered because of the intubation. It's rather triggered by the thermic manipulation. So wouldn't the intubation not be safer in case of having a crisis than the non-intubated procedure?
The question for me, I suppose.
I think for both of you, but indeed the manipulation. I think that will be better question for Professor Pompeo. It's.
I believe that the status of the disease could be well studied in the preoperative evaluation of our patient, and to make the better choice for a single patient to avoid problem during the operation. When we have a deep sedation and good management of the airway, this problem is not particularly relevant about me, because it's possible to ventilate the patient. It's possible to assist with very, very ultra protective ventilation technique, for instance, by CPAP in spontaneous ventilation, or otherwise we can use protective pressure support ventilation to ensure a good gas exchange and without any particular problem nowadays in our cities.
I can add that that one of the main problems with non-intubated anesthesia in myasthenic patients in thymectomy, for example, was in awake patients the risk of opening of both pleural cavity during a manipulation of the thymus. This was dangerous because the risk was to abolish the spontaneous ventilation by causing a bilateral pneumothorax. This has been reduced, importantly reduced, abolished, let's say, by using a laryngeal mask with, as Professor Dauri said, the possibility to ventilate with positive, with CPAP the patient, and so this risk has vanished, has been minimized. Another risk is actually that of manipulating the thymoma. The size of the thymoma is of paramount importance when deciding if operating these patients by non-intubated anesthesia or not. A small thymoma can be operated in our hands by non-intubated anesthesia because manipulation is deemed to be minimal during all the procedure. Whereas for a huge thymoma, we would never use a non-intubated anesthesia for such a surgical procedure. Thank you.
Okay, thank you. And a few other questions are going on the theme of obesity in easy procedures, but also in other procedures. Here the example was biopsies. Do you consider morbid obesity, so in BMI of more than 30, a relative or an absolute contraindication? And I would add, and why?
Yes, morbid obesity is a relative contraindication, in my opinion, not an absolute contraindication. The contraindication is due to the fact that in morbid obese patients, diaphragmatic contraction is important and occupying a big percentage of the pleural cavity. So since the surgical maneuvering, technical maneuvering in non-intubated VATS is a little bit more difficult because of the rhythmic diaphragmatic contraction, In these instances, with a morbid obese patient, surgical monitoring can be a little more difficult, still more and more difficult. This is why is not an absolute but a relative contraindication in our hands.
Yes, I can add an observation about this problem that depends on the type of the obesity, because the pure obesity is that is prevalent in the females is a little bit different from the upper obesity that is prevalent in male population. Because in this second situation, there is a higher representation of abdominal obesity with a more or less important impact on the functional residual capacity, and it's very important in this kind of patient to decide if the contraindication is relative or absolute, to have a spirometric preoperative study.
Mm-hmm. So you don't have any. I'm sorry. You don't have any cutoff for BMI. It
could be 30, 32.
We use the cutoff 30, 32.
Okay. In case of next question, in case of an intraoperative major event, what would be your salvage strategy since the patients are in a lateral position? I think that's a very important question.
Yes, this is so if we have a laryngeal mask is generally quite simple and possible to pass through the mask and endotracheal tube, monolumen, and then it's possible to use a bronchial blocker. This is the technique that is described in a recent paper, is an recent consensus. Otherwise, it's possible to intubate the patient with video laryngoscopy in lateral position without particular difficulty generally. Mm-hmm. Or proceed to the ventilation if the hemodynamic is stable, air and the gas exchange is good with the laryngeal mask, with extraglottic procedure.
Okay. Thank you. In a primary spontaneous pneumothorax surgery, and the surgery is done and with the pleural abrasion or pleurodesis, is this well tolerated considering the pain during procedure?
Yes. Yes, this fear is understandable. But the clinical and the surgical practice, we have seen that neither pleural abrasion nor talcage, for example, in recurrent pleural effusion, is compromised by non-intubated anesthesia because the patient can tolerate pretty well these procedures if even by simple intercostal block with good sedation and optimal postoperative analgesia. It's not necessary, as we thought before, that to put a thoracic epidural to perform this procedure. The simple procedures are now performed by intercostal block and sedation.
Okay.
Yes.
Okay, that's good to know.
This is nowadays there is one more technique that I don't mention before, that is anterior serratus plain block. But in our experience, the epidural is continuous epidural anesthesia is a gold standard probably, in more complicated cases. Otherwise, the other technique are the same. The same results we have with S block, intercostal block, paravertebral block.
Okay. Next question. Does a surgeon need to wait for the patient awake after surgery or after anesthesia? I don't get that question actually. If Lin Wang could clarify this question, maybe, or do you?
Well, I didn't understand well the question.
I also didn't. Maybe go to the next one then. In the case of a thymectomy, what happens if you enter the contralateral pleural space with subsequent bilateral lung collapse? So that's what you explained already with the laryngeal mask, I think.
Yes.
That you can bypass this problem with the laryngeal mask and give some positive pressure there. Would you comment on this? Do you have an extra comment on this, or this is clear, I think? Okay. Then what is your experience with air leak during and after lung volume reduction surgery when you perform the procedure under non-intubated anesthesia? So with the fragile lung parenchyma and still being overinflated, I think that's a very important one as well.
Yes, this is an important question, of course. We actually have, as you have seen, not directly talking about air leaks, but the morbidity was meaningfully reduced by using not only the non-intubated anesthesia, which play not a major role in this sense, but the non-resectional method. The non-resectional method plays an important role in reducing the pulmonary air leaks which were observed by resectional lung volume reduction surgery. So by adopting a peripheral plication of the lung, multiple plications of the lung, we have drastically reduced postoperative air leaks, and the patients now can go home within 5-6 days on average, which I think I can suppose is quite a good result for patients with severe emphysema. Mm-hmm. So the reason is not non-intubated anesthesia cannot reduce the air leaks, is the non-resectional method which can reduce the air leaks.
Yes, I agree.
But the fact that you don't have any positive pressure on the lung would also help, no?
Sorry?
The fact that you don't have any positive pressure on the lung would also help.
Of course. The patient is under spontaneous ventilation, mm-hmm. And this is another important point. You are right, Levin. And also for lung re-expansion at the end of the procedure, we don't use big positive pressure ventilation, but we almost let the lung re-expand by applying negative pressure by the chest tube, yes, into the pleural cavity, which is more physiologic than applying positive pressure from inside.
About me, about this problem, I mentioned some minutes ago the technique of ultra protective ventilation, but in this case, I prefer to use manual assistance, totally limiting the peak pressure on the operated lung, because this is very dangerous. And we, like Professor Pompeo said, is very important to prefer the negative intrapleural pressure than use high peak pressure in the airways of the patient.
Okay. And then a question on protocols. Are there protocols, standard protocols to standardize non-intubated fats? Yeah, I think, of course, I've seen that in your center as well. So I think that's also very important to standardize it. But if you have any comments on that?
Well, they are appearing some papers, collective papers, particularly in China, which are trying to standardize the non-intubated approaches, for example, for the so-called tubeless VATS, which is an extended kind of non-intubated thoracic surgery without use of also of the chest tube at the end of the procedure, and attempts of standardizing non-intubated thoracic surgery. Even though consensus statements for non-intubated thoracic surgery, at the best of my knowledge, still does not exist. But I think it should be time to start in doing it.
Mm-hmm. Then some practical questions, always interesting as well. Can you only do this by uniportal approach because of maybe the pain or something, or can you also do multiple port approach? Or
with the so-called minimalist thoracic surgery, one of the prerequisites for in the definition of minimalist is the single incision, single thoracic incision, so uniportal approach. But again, we prefer this kind of approaches for selected procedures, pleural effusion, primary spontaneous pneumothorax, bullectomy, lung volume reduction surgery, wedge resection, not for lobectomy or segmentectomy.
okay.
For thymectomy as well, we use a single incision, but not for lobectomies.
Okay. How do you manage potential cuff? Patients starts to cuff during the operation. That's very annoying, of course, because then the mediastinum goes up and down, and the diaphragm as well. How do you manage that?
The problem of cuff is necessary to block the thoracic vagus nerve to avoid the cuff. And we do it, is done by the surgeon. Direct infiltration of the vagus nerve in the thorax.
Okay, so
otherwise it's possible to make an ultrasound guided cervical approach to the vagus nerve, but we have no experience.
Yes.
We do it by surgeons.
Intraoperatively.
What we have seen is that it was much more frequent when we performed non-intubated thoracic surgery in a fully awake, in conscious patients. Was more frequent the problem of coughing. Probably, I don't know, Professor Dauri agrees. With the spontaneous ventilation with sedation, the problem of coughing is drastically reduced.
Drastically reduced.
So we seldom encounter this kind of problem today.
Okay.
It's very common during a wake. That's is not absolutely common during sedated. Particularly, if we use remifentanil, this reduction is very, or opioid in general, the incidence of coughing during surgery is very, very low.
Okay.
We use like an anesthetic protocol, because I didn't describe. We use total intravenous anesthesia with propofol and remifentanil or sufentanil. And we use for propofol TCI, and we monitor the adequacy of anesthesia with monitoring of entropy. We keep the entropy in 60, maximum 70%.
Okay. In case you cannot,
we don't have.
I'm sorry, in case you cannot become a good collapse of the lung, is that ever a problem, or do you just have to wait a bit more longer?
Yes, so the problem of the lung collapse must be taken into account in patients with hyperinflation, for example. So in patients with severe emphysema, it can be a problem. And this is the reason that led us to prefer a uniportal approach from lung volume reduction surgery, for example, for a typical upper lung lobe emphysema on the fourth intercostal space anteriorly, which can allow to manage very well both anterior and posterior aspects of the pleural cavity to cut and coagulate pleural adhesions, for example. Mm-hmm. And with our technique, it is not necessary to achieve a complete lung collapse during lung volume reduction surgery. In other patients with nearly normal lung elastic recoil, for example, young patients with a primary spontaneous pneumothorax, it's important to remember that the degree of lung collapse is almost the same that you can achieve in a patient under single lung ventilation. I recommend to try to operate a young patient with a normal lung elastic recoil, and you will see that after opening of the chest, after inducing a surgical pneumothorax, the lung collapse is almost the same that you can achieve by single lung ventilation. The same is happening, for example, in patients with interstitial lung disease, in which the lung elastic recoil is even increased than the physiological one. So the lung collapse is immediate. And so the surgical maneuvering is much facilitated in these patients.
Yes, and the re-expansion of the collapsed lung in this kind of patient is difficult because there is the resistance is very much higher in collapsed lung than in the independent lung. So you quite never have problem.
Okay. Can Professor Dauri comment on the pitfalls of high flow oxygen anesthesia? A question of Professor Lewis.
Yes. Yes, we have not we used a few times, but the advantages of high flow nasal oxygen in a awake patient is absolutely evident in terms of gas exchange and no problem about surgical approach, because there is no risk of re-expansion because the PEEP and is limited, and the gas exchange appear from the beginning, but we generally have no particular problems by this kind of aspect of intraoperative management of our patient generally. But is really about me is a promising technique in a awake patient is very, very interesting.
Mm-hmm. Okay, thank you. It's almost 7. We have many questions. Some of them are coming back. What do you do in case you needed to convert urgently to an intubated anesthesia? But I think then you put the patient deeper asleep and you put in a single lumen tube. I understood.
In case of emergency, about me, is important to make don't have in these circumstances problem of airways. So the most common in few cases we intubate the patient in lateral position with video. This is our standard, but in some cases, in which the situation is not so dramatic, for instance, in condition in which there is the necessity to convert, it's possible to pass the tube through the eye job, for instance, or through the intubating laryngeal mask. This is possible.
Mm-hmm.
With the use of bronchoscope. It's very easy. There is no problem. If you have a medium experience in the use of bronchoscope through the laryngeal mask, is very, very easy. There is no problem. Otherwise, video laryngoscope in lateral position is quite easy. There is no problem at all about it.
Okay, then probably because it's already 7 o'clock, I will first just publish two questions Professor Dauri and Professor Pompeo had for the audience, and then you can already vote there. So in your right side bar, you can see in polls that there's two questions. One question is, do you believe that non-intubated thoracic surgery can offer some advantages over standard general anesthesia with tracheal intubation, and single lung ventilation? And the second one is, are you personally involved in non-intubated thoracic surgery in your center? So you can answer these questions in the polls section in the right sidebar. You can vote right now, and in the meanwhile, we can answer some other questions.
Yes.
Also a question that comes back: what is your strategy if the CO2 is too high? So if you have a high CO2, do you just leave this as it is, or and what is the highest you go? Can you comment on that?
Yes, if CO2 is quite high, this is a problem we use generally to help the patient with if we have laryngeal mask, is to superimpose pressure support ventilation to make the patient to correct the respiratory acidosis, and eventually, if the situation is out of control, is suspend the surgery, intubate the patient, and go ahead with conventional technique generally.
Mm-hmm.
But in our experience, the cases of uncontrollable, not controlled hypercarbia is not common. I don't remember.
Let's say that also that if compared with hypoxemia, hypercarbia is less important in our hands.
Yes.
What we have seen, for example, in patients with severe respiratory impairment, is that quite commonly PaCO2 is rising at the end procedure, even above 70, 80 millimeters Ag, sometimes around 100 also. But what is very important to note is that by non-intubated anesthesia, 1 hour after the procedure, the PaCO2 will be 40. And this is very important. Whereas the contrary will happen in patients under general anesthesia. At the end of the procedure, probably the PaCO2 will be 40, but 1 hour later, it will be 60, 70. And it will remain high, possibly, for a longer period.
Yes. In this case, it's important to monitor to avoid respiratory acidosis decompensated. This is problem. But honestly, I don't remember in the last 2-3 years a scenario like this.
Okay, maybe a last question to end with. Where do you draw the line between two categories? A question from Martin Hurtgen. So the really awake one, which we just sedation, no laryngeal mask, and the non-intubated VATS with laryngeal mask. Where do you draw the line for procedures doing this really awake or non-intubated sedated? Do you have any comments on that?
I believe that making experience with the use of intercostal blocks and laryngeal mask with sedation and target control sedation, as Professor Dauri said, we have gradually reduced the number of procedures which are now electively performed in fully awake patients. I remember that probably the last patient I have operated under fully awake conditions was a patient with a huge anterior mediastinal mass, and we preferred in that case to operate him by a fully awake anesthesia. Intercostal block, simple intercostal block, he was talking with us and ventilating spontaneously. But the procedure was just to make a mediastinal biopsy to achieve a diagnosis. Otherwise, I think that in most of instances now, laryngeal mask plus sedation is more comfortable for the patient, is easier for the anesthesiologist to manage perioperatively, and is to be preferred over the other types of anesthesia analgesia methods.
The choice could be conditioned by the volunteer of the patient, because you can find some patients that refuse general anesthesia or deep sedation. They want to be awake. In this case, could be an indication, could be an absolute contraindication to use sedation, obviously, because there is the refusal of the patient. Otherwise, recent paper of his expert consensus state that use of deep sedation, laryngeal mask, can extend the duration of the surgery to 2 hours, because if the patient is awake, the classical limit stated for surgery is 1 hour. So with this kind of technique, we can extend 1 hour more the length of the surgery. So this is another aspect, and could be
okay. That's good to remember, I think. I see that there's a problem with we lost the screen again, but let's go back to Ant. I hope if you can log in again meanwhile. But let's go back with the audience to the polls. To Ant. The first question: we believe that non-intubated thoracic surgery can offer some advantages over standard general anesthesia with regular intubation and single lung ventilation. There, more than half of you are saying both B and C, yes, high-risk patients with inverted pulmonary function, and yes, in simple and easy to perform surgical procedures. So I think the same as what our experts here told us today. Also interesting, the second question: are you personally involved in non-intubated thoracic surgery? There we see that let's say 55 and 17, almost half of the audience is saying yes, but most of them rarely and not routinely. But the other half is saying no, but I would like to start. So this is very promising for the future. for me today, this webinar was a great webinar again, with more than 175 live attendees and many more to watch later. I think many interactions, and on behalf of the ESTS Learning Affairs Committee, I would like to thank Professor Dauri and Professor Pompeo. They just lost connection, but I will send them my regards. And for the excellent webinar today, of course, and you, the audience, for your interest and interaction. Oh, there they are back. So thank you again, Professor Dauri, Professor Pompeo, for this excellent webinar today. I hope for the audience to see you all next month for the multidisciplinary webinar on the oligometastatic lung cancer. Thank you again, and hope to see you next month. Thank you.
Bye-bye.
Thank you very much. Bye-bye.
Thank you.
Thank you.